Excellent. So thank you to my collaborator and partner, Stephanie Nunley, over from our Career Education Center, for our ongoing series of employer chats, so social work employer chats. I'm Sandra Despain. I am the Associate Director of Student Support and Alumni Networks. And in all of that is the careering, some of the careering aspect of it all. And so we are pleased to put together this event to learn more today about MGH Brigham, and to have our speaker, Bonnie Mullins, here to talk a bit about a day in the life of social work in her setting, and to hopefully with that allow for some exchange of questions towards the end. But it's really just a walkthrough, and it's Bonnie's show. And so welcome, Bonnie, and you can begin at your leisure here.
Hi all, it's good to meet you over Zoom. My name is Bonnie Mullins. I'm a clinical social worker at Mass General. I'm just gonna actually change my view so I can see everyone, just with a nod, heads. Have people been interning at area hospitals? Have there been folks who've been? Yes, so I see some nods there. So you do get a taste of what I do for work. I've been a hospital social worker for the last 10 years at this point, 6 years at Mass General. And I have a few things that I can sort of offer initially as an intro, but then am open to questions. We can make this as informal as possible. So again, I've been working at Mass General for about 6 years as a transplant social worker. There are definitely different areas of practice that social workers are involved in at Mass General, but as a hospital social worker, essentially you are walking alongside patients in some of the most difficult times in their lives, helping to assess some of the barriers that they might have to receiving care, pursuing care. I think one thing to remember is that, and as you probably can anticipate, people don't come to the hospital to see social workers. They come to see their doctors and nurses and receive medical care. But oftentimes we know that there are many things in someone's life that can be a barrier to them receiving care or even being receptive to care. And that's where our discipline comes in to not only help support the patients, but also support the treating teams. As a transplant social worker, our jobs are actually a little bit more specific. So I don't know how many people are familiar with the idea of transplant, but at Mass General, we have a solid organ transplant center. And essentially, we transplant patients who are in need of heart, lung, liver, and kidney, pancreas transplants. And for transplant programs, it is a requirement that patients meet with a social worker and complete a comprehensive psychosocial evaluation. And this is required by the Center for Medicaid and Medicare Services. So in many ways, it does give us an in very easily because they're required to see us. But at the same time, you are trying to get a lot of personal and intimate information from someone you just met 2 seconds ago. So it is an interesting challenge. We all obviously learn to build rapport very quickly with these folks, but also be able to create a safe space for them to learn about what this could mean for them and their families. Typically, a transplant social worker will spend, I would say, about an hour or so with a patient in evaluation. This is in the outpatient setting. And then they're kind of followed through the process until they come to the hospital to receive their transplant. And depending on the organ, that wait time varies. And I won't go into those details unless people are interested, but just know that someone can be in evaluation for anywhere from a year to 8 years, depending on their organ. And they are followed by these social workers until they receive their transplant, in which case they come to the hospital and most of them then meet me. I actually work in the inpatient setting now, supporting patients after they receive their transplants and then seeing them through to their discharge from the hospital, where I then pass them off to my colleagues who work in the post-transplant setting. So these are clinic settings where patients go over their follow-up appointments, and their follow-up appointments are going to be for the rest of their lives. they will manage these organs for the rest of their lives with immunosuppression. So that's medication to suppress their immune systems so that their body doesn't start attacking their new organs. They have frequent follow-up appointments with their medical providers, and then also frequent lab work to make sure that we're getting ahead of any challenges or concerns before the patients become symptomatic. Social work, again, there's so many points of intervention for us along this spectrum, obviously from the very beginning in terms of their evaluation process, but also supporting them throughout. As someone is waiting on a wait list, there's a lot of challenges and anxieties that can come from that. Someone's social situation could change drastically from the time they're evaluated to when they get transplanted. One of the major requirements for patients to receive a transplant is to have adequate social supports, and that could change so quickly, even within a year for some folks. And so we just sort of support them and follow along and help problem solve until they get to transplant, and that's where they see me. In the hospital setting, as many as you can imagine, it can be overwhelming, and it could be triggering for many folks. They become very vulnerable in the hospital setting, and they meet so many providers because Mass General is a teaching hospital. So they will see, I call them hordes of physicians, but essentially that's what it is. They'll have the head physician who comes with his fellows and his med students. There'll be nurses, they all round at the same time. So for a patient, who is not comfortable in the hospital setting, imagine sitting there and having, 12 people come into your room to start talking at you. It is very overwhelming. And this is right after they just had a large surgery, right? So there's a lot for them to sort out. And even that's beyond that, just even thinking the concept of receiving an organ from somebody else whose family, who's died, the family has made a decision to donate their organs, it can be very heavy for a lot of our folks. And starting the process of debriefing and reflection, that can start there in the inpatient setting as well. And then any challenges that we identify in terms of challenges to their care or any barriers to them successfully pursuing care in the post-transplant setting, I will sort of give that handoff to my colleague to say, hey, let's watch out for this because I want this patient to be successful. These are the things we talked about. Can you follow through when they get to your clinic? So, we do have a nice team in transplant social work, and we do work very closely with each other, just kind of communicating about patients on a regular basis so that there is this continuity of care, at least with our discipline, because like I said, they will be seeing so many providers throughout their transplant course with us. And sometimes it's just really nice to have one or two people that they recognize and have been working with for some time. I'm going to stop there and invite any questions.
Yeah.
And it could be questions about my own position now or, other types of social work positions in the hospital. Sandra, go ahead.
Yeah, before you go into questions, just wanted to, I failed to say who possibly could be in the room, okay? Because we have a wide continuum of programs now, and we kind of open this up to everyone. So we could have bachelor level BSWs who we just want to get them exposed to the possibilities, right? As well as our MSW online and on-ground students. So meaning you may have folks from other states. We also have a healthcare certificate, which you may know about on ground. And so several of those candidates may be in the room as well. So that's really just so that you know who's possibly here. And please feel free, folks, to use this time to ask other questions.
Hi there. Thanks for the presentation. I've got a question. If you haven't done your internship in a hospital setting and you haven't really had any direct hospital experience, but I've certainly had a wide range of different experiences throughout my career before getting licensed as a social worker. What are the opportunities to actually get your foot in the door at somewhere, at Mass General or indeed any other hospital?
That's a great question. And, it used to be that having an internship in a hospital setting, it really does set you up well for employment at a hospital. However, I would say one of the things that we've noticed since COVID is that there is a competition for social workers away from hospital settings and community settings where, folks are finding that you can go into private practice early on and work for yourself or work, in a counseling center and work from home. I think that's been a really big draw. And so we have been inviting folks who don't have any hospital experience to come work certain positions in hospitals. That being said, obviously, if there are specific positions that require some hospital experience, you'll be aware of that, definitely. But we have had, folks come in, working per diem positions, working float positions, being exposed to a hospital setting with some training and some support, and then potentially moving into a floor or service of their own, right? So per diem positions are a really great way to get your foot in. I would say emergency room social workers too, although it sounds crazy and it really is, it is a really tough place to work. You do get a lot of exposure to what you might be seeing all over the hospital. And, there's always the need for emergency room social workers, whether it's floats, per diems, at any of the area hospitals, really. I started at Boston Medical Center. I had a hospital placement during grad school, and they hired all new grads when I entered. So we didn't have, a lot of us had hospital experience, but not everybody. And it's a steep learning curve, but some of it is highlighting the skills you have that can be transferable to working with folks who have chronic illness or who, working with folks who have trauma. You think about what you highlight in terms of your skills. And I think that, again, we have seen many more people apply to positions that have not been able to work in a hospital before.
No, thank you. That's really helpful. And with respect to like online, because I do work in a counseling center doing exactly that. I do a combination of in-person and through Zoom. Are there opportunities, to work sort of partial remote?
So there are, again, there are different areas of practice here in the hospital in social work, and we do have a mental health group. So they essentially do counseling, mostly for our patients who are referred by their primary care doctors here. And then they also, they see employees and staff. And so they do also work remotely. And it's, for many of them, they work entirely remotely. And there's some who do come in to see patients face-to-face. That's their preference. I think some folks just don't want to work entirely remotely, but there are those options. We do have some outpatient areas of practice where they might do a hybrid schedule. So there's like some days where they're on site just because of how convenient it is for the patients, but also for the staff to be able to interact with the staff members here. And then also to then do some of your patient work from home. I see hands raised, so I'm going to unmute Erin first. Erin Stevens North.
Hi, let me unraise that hand because there we go. So I'm an MSW student. I'm going to be graduating in the spring, and I'm placed at Tewksbury State Hospital currently. I was wondering if you could talk about the psychiatric services that MGH offers and how clinical social workers can get involved in these opportunities.
So there are sort of two arms in terms of the psychiatric care and where social work is involved here. So there are social workers who work for the social services department, which is what I'm a part of, and they staff our psychiatric unit here at this hospital. It's Mass General Blake 11. If anybody's been referred to, referring folks to Mass General, you know that. We have social workers who staff that floor. Then there's a whole other department of social workers that work under psychiatry. And so they, and that's an area that I'm not as familiar with, but there are social workers who work closely with psychiatrists and psychologists under the Department of Psychiatry. And they also do direct patient work along with evaluations and assessments, and long-term work with clients. So there's actually two. So if you're looking, all I have to say is if you're looking, it's not just social work under Department of Social Services, but under psychiatry, there would be positions open as well. Stephanie, was it?
Yes, hi. I'm also going to try to figure out, there we go, lower my hand. Thank you for the overview that you presented. That was really helpful to get a sense of the different kinds of things that you do through your day. So I'm someone who has a lot of exposure to the hospital setting, and I have my own perception of what the day in the life of a hospital social worker is like, but it would be helpful to hear what you feel like your day-to-day looks like, or what you think, if there is such a thing as an average hospital social worker day-to-day, what that kind of looks like.
So my day-to-day as an inpatient social worker at this point entails attending multidisciplinary rounds with my team. I have a team that's based on the floor. So I work on the transplant floor itself. So I have a team that's based there. I round with them in the mornings. We discuss the patient's medical concerns predominantly, but I'm there to sort of fill in the gaps about, what potential barriers there are for these patients in terms of being receptive to care, especially when they're having a difficult time with their providers, or there's, some other psychosocial concern that they had come with that wasn't really addressed before they came to us. I try to fill in those holes during those rounds. And then I round with the team. I meet with the patients as teams are meeting with the patients just to get a sense of what they're being told by their medical team. Being familiar with hospital setting, I'm sure you've heard, the patient says, I heard this, and the doctor says, no, I didn't say that. It's really helpful to be present when that conversation is happening so that it's easier to address afterwards. And also to say to the medical team, look, you weren't clear about that. This is their understanding. You need to go back and have that conversation with the patient or family. And then I respond to a whole host of consults that are placed for me. So being a hospital social worker does mean that you respond to consults placed by other providers that are not social workers. So a medical provider might go in, see their patient, identify a concern, and then say social work needs to see them. I have very different feelings about this because I often feel like the consults are placed because of the anxieties of the providers, not necessarily what the patients might want. I always then go back to the provider who places the consult and asks a couple of questions. One being, does the patient know that you've asked social work to come see them? And secondly, what brought on the concerns, what part of your conversation brought on these concerns? How did the patient get to even expressing those concerns? And kind of getting an understanding of where I need to start when I go in to see a patient. So, the worst thing you can do is not have that conversation, go in and say, hey, your doctor wanted me to see you, and, chaos can ensue. So there's a lot of consults that go in for social workers to address. A lot of them are really require assessments more than anything else, and for us to really assess the needs of folks and whether or not there can even be interventions. One thing that my colleagues and I talk a lot about is that, these patients that come to us are quite resourceful and may know more about the resources in the community than we do. And so for us to go in and try to give them information that they already have, I don't think is really respecting the patient. So having an assessment first, understanding what the concerns are. Oftentimes I find that it's not really what the provider identified for the patient, but a whole different concern. And so I'll do that through most of the day, just respond to patients, respond to the consults. And then I follow some folks long-term while they're in the hospital. So I have folks who are here anywhere between 2 weeks to 6 months, and so I do check in on them very regularly and sort of support them and their families up until the point that they're discharged from the hospital. One thing about social workers, the inpatient social workers at Mass General, is that we don't directly do discharge planning. So we are involved in the sense that if there are concerns around discharge, certain concerns that we can address, or what I consider challenges to a safe discharge, you may be involved. But in terms of the actual referrals to rehab or visiting nurses, that's typically done by our case managers on the floor.
Thank you,
Does that
Bonnie.
give you a better sense, sort of?
Yeah, thank you. That's very helpful.
Okay.
Thank you, Bonnie. Before we go, I see two more hands, and I want to make sure that we get to Bianca and Mies and whoever else is out there. But I failed to introduce another party that's here with us from MGH, which is Natalie Moreno, who is here to, as you're asking your questions, she's from HR, making sure that you are thinking broadly as well. And we do have an expert in the house that can tell you about that the hiring and the onboarding and all of the other aspects related to vacancies for social work positions there. So just wanted to call you out, Natalie. Thank you for being here as well.
Thank you for having me, Sandra.
Great. Okay, so with that, we'll continue. And I see Bianca's hand, so I would like you to jump right in. Thank you.
Hi, thank you very much for that. So I guess I kind of have two questions. I appreciate you going through what your day-to-day looks like, because that was also a burning question on my mind. But you had mentioned that where you follow patients for the assessment portion, and they could be in assessment anywhere from 1 year to 8 years. I was curious of what that meant. Are you providing therapeutic care to them? Are you, what exactly that means? And then I guess the second question is, so I currently work at MGH in the Cancer Infusion Center, and I've been becoming more curious about the Cancer Social Work Department and kind of what that looks like. I had a couple of MPs that brought it up to me once they found out where I was going to school and what for. And just in getting to know the patients, I've been becoming more and more curious of what a cancer social worker would look like and what's involved there. And that's I don't know if that's more of a question for Natalie, but yeah.
Natalie and I can tag team on that one. So I work pretty closely with some of the cancer social workers here. But let me address your first question first, because that is very specific to transplant. Like I was saying, I wasn't going to go into detail unless someone asked, but depending on what organ you need a transplant for, your wait time, so the time where your evaluation is done to when you receive that transplant, could be anywhere from 1 year to 8 years, right? So for instance, if you're waiting for heart transplant, lung transplant, sometimes your evaluation can take up to 1 year, and then you might wait 6 months to 1 year before you even called in for surgery. Kidney transplant, you can wait anywhere between 5 to 9 years for a transplant after your evaluation. And the social workers in kidney transplant do not follow the patients so actively. So we're not calling them regularly. We're not seeing them on a regular basis. Some of them are on dialysis. So they have social workers at dialysis centers who do keep up with them. However, if a concern is brought up, let's say one of our nurse coordinators who does touch base with the patients on a regular basis, they speak with the patient, they identify a concern, they can ask any one of the social workers to call the patient, right? And so we don't actively follow them, let's say for the entire 8 years, but we can be called upon for any concerns for any of the patients on our wait list. And just to give you a sense of what that's like with kidney transplant, our wait list is 1,300 patients. We have 3 kidney social workers. So at any given point, anyone can be called upon to call one of those patients if a concern comes up. Now, when the patients are getting closer to the possibility of transplant, there's some computer algorithm that sort of helps us anticipate when someone could potentially be called in. It's not a really precise time frame, but some of these patients do come back to see us to be updated, because again, if you've been waiting for 5 years, you only saw us in year 1. We don't know anything that's happened between year 1 and year 5, right? So they do come back and see us for a follow-up as they're getting closer to the possibility of transplant. And again, the algorithms are based on something very clinical, like if their blood type, for instance. Like we know on average, national average, that a patient with a certain blood type might wait 5 years. So if you know that a patient has that blood type, you know that they'll be coming up after the 5-year mark. They may come back to see us in clinic. Does that answer that part of the question?
It does, thank you.
Okay,
Sorry, I
yeah.
couldn't find my unmute
Yeah, so it's
button.
it's very specific to transplant, but it's really being available to provide that support to any of the patients on their wait list. In terms of the cancer part of it, so actually I was an oncology social worker at BMC for a little bit, and a lot of the social workers here do something very similar in the sense that there are outpatient oncology social workers and inpatient oncology social workers. The outpatient folks obviously will see their patient as they come in for their appointments with their physicians in the outpatient setting. So again, in general, when someone is receiving the specialized care, they will have, you know, an outpatient component and likely an inpatient component, right? Outpatient being seeing their oncologists that follow on a regular basis for updates or any kind of like testing that they need updated. Inpatient, if there were any complications, for instance, or progression of disease, or they're in the hospital for specific treatment, like stem cell transplant, for instance, excuse me, or bone marrow transplant for some of our oncology patients, they have to be in the hospital for at least 30 days. You know, so they'll have inpatient social workers there. And it's harder for me to explain a day in a life there per se, but I do know that my colleagues follow patients on a more regular basis, and they will try and see them at, you know, maybe not every clinic appointment, but every other. And it's really it's supportive counseling in many ways. It's just helping patients come to an understanding of their diagnosis, come to terms, you know, adjusting to their treatment and their treatment plans, or what's happening to their bodies as they're going through treatments. You know, how is this affecting their families? You know, anyone managing a chronic illness may be familiar with this, but the guilt that comes with the burden that is placed on family members or friends, or the fear and anxiety that comes with going through this alone. You know, there are so many things that could be affecting how a patient is feeling while they're receiving treatment, right? So it's not even just the treatment alone, but it's all of this around that. So that's part of what, I mean, definitely what I did at Boston Medical Center, but a lot of what our folks do here.
That's great. That's great. I want to see 2 more hands. Want to make sure they get
Thank
their time in. So, Emmy's, is that correct?
Yeah, it's Emesha, but I usually go by Emmy.
Amesha. Oh, I'm so sorry.
Mesha,
didn't
nice to
edit
meet
it.
you.
Sorry, I forgot to change my nickname in there. So I read a little bit about you beforehand in the description we got, and it mentioned how in your general work, you tend to come across ethical issues that patients are struggling with. I'm wondering if there's an example you could give of a common prevalent issue ethically that tends to come up that you have to.
Yeah, so that's a great question. I think the common one that we see is the question about escalation of care or continuity of care when it is unclear if that's what the patient had wanted, or if we feel like it's futile, right? So, and that opinion could come from either side. So it's not as cut and dry as family wants this and doctors don't want that. It could be the other way around too. Family doesn't want this, doctors want that, right? So, so that's from my participation in those meetings. That's been more of the prevalent issue. Is, you know, and typically when a patient is intubated and sedated and they're not part of this conversation, you are having providers who know the patient well, and then family, I don't know, also weighing in, and sometimes it's not the same opinion. So that's really what I see a lot in these discussions. And then there are other ones, you know, that are, I mean, I wouldn't necessarily say ethical concerns per se, but, it does touch upon, a specific provider's anxieties about how treatment is going, or how the family is taking care of a patient, or how they're, trying to direct care that does not seem comfortable for them. And so we do discuss those things as well, but the predominant one has to do with this conflict of whether or not we continue on this course when it is really unclear whether this is something that the patient had wanted in the first place.
Thank you.
Thanks. Ian.
Hi, thank you for sharing all this information with us today. I have a couple of questions for Bonnie and then one for Natalie. So in your experience, would you are working full-time in the hospital, or are there people that might also be working outside of the hospital in private practice, for example? That's one question. So they sort of.
Sorry, so before you continue, you got cut off a little bit. So can you just repeat that question?
Yep. So I was asking for the hospital social workers, regardless of the department, is it typical at all for them to also have an outside private practice, or are they working exclusively in the hospital full time?
A lot of my colleagues have a side practice.
Okay.
It's part-time mostly because many of us work full-time here, but for, full-time can also be 32 hours, and they might spend another part of their day or their weekend seeing clients in their private practice.
Okay, great. And then for the patients that you're working with when they're inpatient, do you typically, if they have the need, would you refer them to outside therapists either during that wait time or after their surgery? Is that pretty common?
Yeah, 100%. Definitely during their wait time, if that's identified as a concern. We know from history, from research, that if someone is struggling with a mental illness that's not treated, and let's be honest, all of us have a mental illness, everyone struggles with depression, anxiety on some level, it can impact someone's ability to care for themselves, and you're asking them to buy into a very complicated medical regimen without optimizing their mental health. We could become into some issues afterwards. So yes, we do recommend that. We don't directly recommend people to a specific provider because we don't have all of those connections. We have to figure out where, obviously where a patient resides and what's most convenient. Now that most people do virtual, that's very convenient for folks. But yes, I do refer out. I don't carry patients after they leave the hospital.
And would those outside clinicians be considered part of your team, like for a case consultation? Like how much would you keep in touch with them to stay current with the patient situation?
Yeah, so we would, depending on what the recommendations are for treatment. So again, with transplant, it's time sensitive, right? So I would love for my patients to stay in treatment for years on end. However, for some people, we can't put that time frame on as a condition to receiving a transplant, right? Someone who has liver disease may not have years. So we do check in every 3 months with the therapists in the community to see, how is the engagement going? Are you actually working on the identified concerns? They usually have questions for us because, sometimes the patients go to them and tell them, well, this is what I need to do. And it may not be exactly what needs to be done according to the therapist that they're seeing. There's a disconnect there sometimes. So I would say every 3 months or so, we would communicate with them until a certain point in some ways, the treatment has stabilized a little bit. And the social worker feels comfortable bringing that back to the medical team saying, okay, this is where the patient's at with their treatment. It feels stable. They're talking about the right things. Let's consider, whether or not we should move forward at this time, or should they still continue to be in treatment? I wouldn't say they're part of our team because I don't necessarily have input as to whether a patient is ready for transplant per se. But I would say that their input is very valuable when it comes to what, they are working on the outside.
Thanks. And then I have a quick question for Natalie, and hopefully this will help everybody also, but just in terms of the hiring process and going through the Mass General portal and applying for jobs and creating the account and all of that, are there other things we should be doing to I guess, bolster our applications or, you know, kind of further, because I'm sure the inbox is filling up all the time with applicants.
Yeah, so that's a great question. I would probably, the first thing I would say and recommend is that, and it's what I call focused recruitment, right? So I would say as a candidate, please be sure that you at least kind of have a sense of what kind of positions you're actually looking for. So what I've seen oftentimes, and I do have other colleagues on the call, so please feel free to jump in, but I've seen oftentimes that a lot of candidates are just applying just to apply, but not really taking the time to review the job description in its entirety and make sure that they're actually focusing on the qualification sections, for example. So are they qualified based on what we list on the job description? And if so, do they apply? So a lot of times from a recruitment perspective, we're reviewing candidates and, you know, they seem really great, but it's not a match. And so I would say, you know, focus on, you know, the top 3 or top 5 positions you're really interested in. The other thing that I would also say is we see a lot of candidates that are, you know, interested in just getting their foot in the door, which is totally fine. But then we see that they've applied to over 100 positions. And so we do try to, you know, stay away from that because we do wonder, you know, what is their real focus here? Are they just applying because they're just applying, or do they really want to move forward with a career with MGH? So I would say that would be a couple of things to keep in mind. You know, if you do apply through a portal and you are qualified, you should be getting a call from MGH. You'll get a call from me. I am the Senior Talent Acquisition Partner for all social work at MGH. And so you'll get a call from me to schedule a phone screen. I would ask that, you know, or the recommendation would be to return my email or call within the next 2 to 3 days so we could get the process going from there. And then the intent would be for us to have a conversation. I'll gather a lot of information that I'll need in order to present you to the department. And based on that conversation, I do make a recommendation to the department, and the department, if they're interested in you, they'll reach out to you directly with next steps. I oftentimes end the conversation with the candidates to say, you know, please follow up with me within the next 48 hours if you haven't heard back from the manager. And that's just a way of us continuing the process moving along, right? So because the departments do get busy, they're doing 100 things, and so is HR. We want to make sure that we're all kind of, you know, touching base so that we could keep the process going as quickly and swiftly as possible.
And just to add to that, you know, I'm a little old school on this, but a cover letter really helps because I feel like a lot of those are missing now from applications, especially when you're doing something through a portal. It doesn't seem obvious that you should include a cover letter, but sometimes it's hard to tell one candidate from the next. I do a lot of the interviewing for my team, and so it's hard to know how, you know, how focused a candidate is on a specific position. And whether or not there are strengths that aren't reflected in their resume that they can include in a cover letter. So I'm a huge proponent of those, just to say.
Yeah, I would just add, if you could make the cover letter very general, that would be great. The feedback that I have received from some managers has been, well, I reviewed Joe Smith, but he addressed the cover letter to the Brigham or to another entity that's not MGH. And so that turns off managers. So I would just say, if you want to submit your CV, that's totally fine. But if you could just address it as a general cover letter, I think that would help you out in the long run.
Great questions, great responses. Thank you, Anne. And but Denise, I know your hand has been up for a bit, so let's jump in.
Hi, thank you. I had a question for Bonnie. Hi. So as you mentioned, like being in a hospital setting can be very difficult and triggering. I'm wondering if you're ever expected to support, like provide emotional support to the medical staff who are having to, you know, deal with very difficult situations, and then how you, being in that setting, kind of compartmentalize that experience so you don't take it home with you.
That's a great question. The first part of it, in terms of emotional support for staff, we 100% do that, whether or not they realize it. Especially if our staff members are directly caring for patients that are challenging in any way. I think some of the more difficult ones are, for at least for my nurses, are the patients who have some kind of cognitive issue. Dementia is usually the hardest one, where they are physically and verbally assaulting staff. but not, not doing that on purpose per se, right? So I think it's really challenging when you, as a nurse, for instance, you have to go in and provide care. You don't have that choice to say, not, they're not ready today. They have to go in and take care of the patient. So, I usually, what I do is I sit on my floor quite a bit, and I make sure that I am aware of every single one of my patients and what they're coming in with and what the concerns are. We have rounds with nurses too, and so they talk about the concerns that they're dealing with in terms of taking care of the patients. And I check in. I always check in with my staff. We've obviously have had, especially when, with COVID, there's been so many challenges in healthcare, and we've created more spaces to debrief those things together. But I think as social workers in the hospital, we often take the leads on those, partly because it's our training. But the other part is that I think as a discipline, we on average do a better job compartmentalizing. So what I found compared to my interdisciplinary colleagues is that we talk to each other quite a bit about cases, about what's happening on our floors, debriefs with each other. That I don't think happens as much in other disciplines. And you let your colleagues support you. You let your social work colleagues support you. They tell you, you need to leave that here, then you leave that there, and so you learn over time ways to leave work at work, and sometimes they may not happen at work. I would say oftentimes it doesn't happen at work, but I leave work on the bus, I leave work on the train. And then it gets really bad. I actually have a little bottle on my, there's a stand I have in my foyer in my apartment. It's an empty glass bottle. If I'm carrying stuff into the apartment, it stays in that bottle. So you learn over time through these strategies to figure out how to leave that, and also understand that at the end of the day, it's a job, and there are many other things in your life that are important and matter. It's really hard because as a social worker, you just really want to help people and you really want to make sure that you're doing right by your patients. But if you're not taking care of yourself, you're not going to be good to anybody. And it's so cliche, but I've personally seen that happen to myself. I think these last 2.5 years in COVID have really stretched many of us in terms of how we've been able to cope and what, learning what our breaking points are. And you have to identify that. You have to learn that for yourself. And I feel like we as a discipline do that better than many other disciplines here in the hospital. But thank you for asking that, Denise. That's a great question.
Thank you. It's a great answer.
Bianca, let's go back to you.
So I just had a follow-up question for Natalie as far as the application process. So I'm an MSW student and I have not gotten my placement yet for my field work that's supposed to start in January. So I don't know if I'm going to be in a hospital setting or a medical clinic or somewhere else. And if it turns out that my internship is not in a healthcare setting per se, and I want to apply to a social work position in the hospital, how much attention do you pay to the actual hospital experience versus the skill set that I've learned throughout my internship?
Yeah, thanks for that question, Bianca. So I would encourage you to apply. I think at this point, I think Bonnie mentioned it, we're looking for social workers everywhere and anywhere, under rocks, anywhere. And so I think at this point, I would advise you to just apply. We look at overall experience, right? To Bonnie's point, yes, we typically or traditionally, we would want to see a resume that has internship experience. But at this time of day, I think, just having your MSW and having a conversation with you and having some sort of experience in the past, whether it's, working some hours in a different setting, not necessarily in the hospital setting, but in different setting, that is okay. And so I would absolutely recommend you move forward and applying. I would also just say that with regards to that piece, if let's say you're graduating in May, I would advise you to start applying, I would say maybe 4 months before that May timeframe, right? So that you could get the conversations going, we could start setting you up. The nice thing is that managers are now willing to start interviewing candidates before they actually have their licensure and hiring them before they have their licensure. So we hire for non-licensed social workers and pretty much wait until the candidate sits for their social worker licensure and hopefully passes. So just know that not all departments are willing to do that, but a great number of my departments are now being very strategic and doing things a little bit different in order for us to help social workers get their foot in the door.
Oh, wow. Thank you.
You're welcome.
Great. I know we are like almost at our time, but Anne, do you have a quick question that you can throw out before we wrap up?
Yes, thank you. It's about supervision and the difference between supervision for, a full-time regular shift per social worker versus someone that's working float or per diem.
I actually don't know too much about the supervision for our floats and per diem. I do know that we, for LCs in particular, we do offer it. I just don't know what their schedules are and how often that they have to, they schedule to meet with their supervisors. But that's one of the nice things about our department here at Mass General is that we do offer supervision for our social workers for LCs and LIs. So as an LI, I'm still receiving regular supervision, which is nice. It is more case consultation most of the time, but it's so necessary. So yes, I'm not entirely certain about that, but if you are an LC and require supervision and this is your position, because our per diems and our floats may be closer to full time, right? So it doesn't necessarily mean that they're only per diem 6 hours or 8 hours. They may be with us for many days. They would need supervision provided by our department.
Thank you so much to everyone, and Bonnie and Natalie in particular for taking the time out of your day that I know are on skates always, and for having a chance to speak to this group of students and letting them know what the possibilities of healthcare social work looks like in a hospital setting. So thank you for taking your time and coming in with us at Simmons today. Thank you all who were able to attend. I know that there will be a follow-up, for those that are not here after the session ends. So I know there's probably a 3 o'clock class for many to run to. So that's the reason that we stop at that 15 minutes to 10 minutes of the hour. So thank you all. Feel free. You have names now within the system. You have your HR recruiter contact in particular. You have a person within the social work department that I am sure will respond to you if you were saying, I was at your Zoom presentation employer chat. So feel free to make those subject lines and connections as you leave here. And thank you for attending today. Stephanie, anything else to add?
Oh, thank you so much for everyone joining. I will stay after a little bit if anybody has any questions or anything. I'm more than willing to email everyone the recording of our meeting today. And of course, thank you so much for everyone for joining us.
Great.
Thank you for inviting me.
Of course, thank you, Bonnie.
Thank you for having us.
That was great. Thank you.
I'm happy to stay on for a few more minutes too.
I can too.
I have a quick question. I raised my physical hand.
Yeah, of course.
I don't know specifically how the departments work in MGH, but is the transplant department include pediatric services as well? So do you work with children or is it largely adult focused?
So my team is largely adult focused. We do have a pediatric team here, and our pediatric transplant social worker sits on the pediatric team.
Mm-hmm.
That being said, we do collaborate quite a bit, but for the most part, she works with the pediatrics team here.
Yeah, it just to add, so we do recruit for specific pediatrics team. We also, so we have social worker positions across the hospital, but we also work with the community health centers out in Everett, Chelsea, Charlestown, Revere, et cetera. And so some of those different health centers, they do specifically have the PD specialty, if you will.
Yeah, I was also just curious if what kind of social work in a hospital setting would be working with children, but that kind of goes, I guess, along those lines.
Oh, I'm sorry. Did you get my answer, or did you have a follow-up?
I guess it's just, could you give a couple examples of potential ways in which you can work with kids in a social work capacity within the hospital setting in MGH?
Yeah, sure. So, so you could work, as I mentioned, in the community health setting, working with children. I mean, it could go from, children, I mean, and toddlers all the way to, 18-year-olds or what have you. So it really does depend on, the age group that this department is looking to have you or the social worker work with. But it's similar to any other specialty. So case assessment, working with them directly. If you're an LC, you'll get supervised. If you're an LI, you're going to be working more independently. We also have departments who do a dual, right? So they'll work with PD and adult at the same time. So be seeing both kind of age groups simultaneously at the same time.
Great, thank you so much.
Just to add to that, we do have a couple of inpatient units for pediatric patients. And there is so there are inpatient and outpatient social workers for pediatrics as well. We do have, the pediatric ICU here. And then there's like even younger, right? So we have a NICU, there's the OBGYN department. So there's like, there's a lot of positions to be able to be involved in the whole, that covers the whole lifespan.
Thanks.
Denise?
Yeah, hi. I was just wondering what the need is for bilingual social workers at the hospital. If you could just talk a little bit about that. Yeah.
Oh yeah, we're all over it. So if you're bilingual, I want to talk to you like tomorrow. That's how bad we are looking for bilingual candidates, especially for our Chelsea office. So I think in particular, just anybody who's bilingual, it brings a huge asset to our NGH family, if you will. But most importantly, I would say, Chelsea is in higher need of bilingual candidates, Charlestown, Revere, et cetera. So as you could imagine, where the high population is bilingual, that's what we're looking for in terms of bilingual. And the nice thing is that, if you're bilingual, not only in English and Spanish, but, another language, Portuguese, Haitian, Creole, French, that's a valuable thing that we actually compensate you for it. So just to keep that in mind, if you are using your bilingual skill sets for, for the role as a social worker, there's definitely a compensation component to it.
Thank you. Thanks.
You're welcome.
Thanks, Bonnie, for sharing your contact info. It'll
You're
say
welcome.
Simmons and you'll know how and I found you. So thank you so much.
Thank you so much.
Any other questions from this group?
I have a question. Just out of curiosity, in terms of next steps, how can the folks who actually attended today's session, how can they get in touch with us if they're interested in talking to us about opportunities at MGH?
Yeah, so I have a note to you asking, are you willing to put your contact info in as well? If you are, that's one way. For our campus base, many of them are looking for, post-graduation, so more May, because we're on a traditional schedule. There may be many that were in here that may, someone said they started in January, so that led me to think that they may be an online person. But again, you gave the timeline on what they need to do and when. We will have this recording published to those who attended as well as those who were not able to attend. That's what usually the post run is on each of these employer chats. And they will have access to the information that has been shared through the Career Education Center and platform called Handshake. They'll be able to get to a lot of the detail that was sent in the promotions through that. And what else can we say? Anything else?
We actually have Mass General Brigham registered for our social work career fair that's happening. And it looks like Cindy Cruz has actually joined us today too. So it looks like you are registered to join us for that event. And it's only for our social work students. So it's only for those students who have joined us today. And of course, for the rest of the students who are part of our School of Social Work. And that's going to be happening on Wednesday, February 22nd from 3 to 5 p.m. in person. So we are super excited for that to happen actually in person. So we look forward to having you join us on that event. And we're definitely going to be promoting that for that event. And this is why we're having our employer chats to definitely open our students to see the different positions that can do with social work and see the different opportunities that are open to them. So we have that, but we're more than happy to share the contact information to our students and send up the follow-up of this this great chat that we had today. And of course, if you have any other open positions that you'd like for me to share, I'm more than happy to share those to our students also and send that information to them.
Yeah, and from my end, from the alumni job board, I can also do that as well. So in my signature, you'll see that there's a space that you can enter in current vacancies and/or contact me directly. So that's great.
Perfect, thank you.
I'm sorry. So I came a little late, so I do want to introduce me before I let you guys go. So I'm a talent sourcing partner. I do work for Mass General Brigham. So I work very closely with Natalie supporting social work positions there. I work with other two colleagues that they joined in. I'm not sure if they introduced themselves, but Ann Paradise, she sits at the Salem Hospital in Salem. So I provide recruitment for them, as well. McLean, my colleague Debbie Dallas, I believe she was in the call. Not sure if she introduced herself, but I work very closely with them as well, including Wellesley, Mass Pioneer, Brigham and Women's, the Faulkner Hospital. We have our community organizations, we have our home health centers, we have urgent care. So as you know, Mass General Brigham, we're a large organization. So if you have any questions regarding any of the hospitals, I'm more than happy to connect with you one-on-one and kind of share with you like what we have at these locations and so forth. So I could put my email here in the chat. And if you have any questions, definitely send me an email. I'm more than happy to connect with you and share a little bit more on a one-to-one basis.
Please do. I'm so sorry, Cindy, did not realize we had other players, and I know it's a large system, but didn't realize there were other players in the house. And wow, for those who hung over, that was smart. You got this live and captive HR talent right in front of you. So wow, thank you for speaking up. Cindy, I was thinking you were one of our current students. So we're glad to meet you and to know the scope of responsibility that you have on this recruitment side. Excellent.
Oh, you're welcome. And I apologize for not introducing myself a little bit earlier.
I'm so sorry.
It's okay.
Well, the lucky ones are here.
Like the time always passes so quickly.
Okay, then the recording. No, everyone will get it. Anything else? Anything else? Any questions related to Simmons? Any questions related to our programming that recruiters would want to know? Okay. All right. We are eager and glad to have students graduate and send them your way. So thank you so much. Thank you, Bonnie, again, for the overview of what it really is in a day in a life. So thank you so much.
Thank you. Have a nice day, everyone.
Bye-bye.
Take care.
Thank you.
Bye.
Bye.
Bye-bye.
Bye.
Bye.
Bye-bye.